This lecture will take you through the summary of the arterial diseases of the extremities and the different types of aneurysms, including emboli formation and thrombus formation. Looking at the arterial diseases of the extremities, there's three main diseases that we're looking at. First is peripheral arterial disease, PAD, or arterial sclerosis obliterans. I don't think you'll see me referring to it as the obliterans at all on the exam. I refer to it as PAD most commonly, peripheral arterial disease, because we also refer to CAD, or coronary artery disease. That'll be in a subsequent lecture. So PAD, or peripheral arterial disease, primarily we're looking at occlusions or blockages in the blood vessels of the lower limbs, most commonly in the femoral and popliteal arteries and their branches. One of the main risk factors for this, it's more of a risk factor rather than a cause. Again, we're thinking arterial sclerosis, and really, if you look at the previous lecture, in atherosclerosis, that's what we're dealing with. So the biggest risk factors are for the smokers, and also it's common in those that suffer from diabetes mellitus. We're just looking at, in terms of manifestations, there's blockages of the vessels. Anytime you have blockages of the vessels, the main manifestations you want to be concerned about is when you block blood flow to those vessels, you're going to lead to decreased metabolism in those vessels. Oxygen can't get there, nutrients can't get there, and there's obviously the risk of, with the ischemia, there's the risk of necrosis development. And that's what we are going to see more commonly with those suffering from diabetes mellitus. Early on, there's going to be that intermittent claudication. Recall what intermittent claudication is, that pain, kind of a burning pain sensation that comes particularly upon moving. Again, it's important to get up and keep the walking going, particularly if they can just walk slowly. It helps increase the possibility of collateral circulation developing, but they have pain while they're doing it, and this can, of course, prevent them from wanting to continue to move. All right, then you have Buerger's disease, or thromboangiitis obliterans. Buerger's disease is more common in young males between the ages of 25 and 40, and if they're in fact using tobacco products. It can also occur in women, although in women it isn't necessarily as directly linked to smoking, and so we would refer to it as idiopathic. I don't think I'd used that word before. Idiopathic, I-D-O-P-A-T-H-I-C. Idiopathic means no known cause, and so in fact with Buerger's you don't even necessarily have a direct risk factor when it comes to it showing up in females. Again, more common in males, particularly those young males who use tobacco products. It affects the small vessels of the hands and feet, and it can also affect veins and nerves in this area. So although we're calling it an arterial disease and we're linking it primarily to the arteries in the hands and feet and lower portions of the legs, it does in fact have some linkages to veins and nerves as well. What you see occurring is inflammation in these vessels, and with this inflammation, a thrombus, which is a blockage, can form, and it therefore blocks blood flow in these small vessels. This is what leads to that the pain sensation. So the manifestations, there is intermittent claudication, usually in the arch of the foot and in the digits of the foot, so the toes, and usually this pain is the first sign. There will be vasospasms, where blood will attempt to constrict, or the blood vessel, I'm sorry, not the blood itself, but the blood vessel will constrict and then relax, constrict and then relax in an attempt to try and force the blood through. Looking at the area, it may first appear red from the inflammation, but as the blood flow, particularly if it's in a spasm state and it's constricting, the area will then turn from pale to blue. There may be decreased or absent pulses in the extremities. Finger and toenails will become malformed and thickened. loss of hair in the extremities. So if there's hair, that's the fine hair that might grow on either on the hands, the knuckles, or on the legs and feet, that will disappear. And in final stages, this too can be continued obstruction that can lead to necrosis and gangrene. The third one, the disease we have here, is Raynaud's disease and phenomenon, and I'm going to break them into two categories. The disease is idiopathic. In other words, Raynaud's disease has no known cause. You don't know what, it cannot link it to anything in particular. And the phenomenon is secondary to other underlying conditions. Raynaud's disease, and I believe there is a picture in your book as well that shows the Raynaud's disease. It's most commonly seen in the hands. It can be in the toes as well. There are vasospasms that lead to ischemia, causing a noticeable color change, first beginning at the tips of the fingers as they'll turn kind of a pale color, and then they'll actually start to turn a kind of a bluish tinge. This is episodic. In other words, the vasospasm comes, there's a lack of blood flow to the tissue. The hands, again, most commonly seen in the hands, they tend to turn blue, and then the spasm will diminish, blood flow, the vessel will relax, blood flow will start to return again to the area, and there's an intense redness that develops as the episode comes to the end, and there's a rush of blood flow to the area, and it can cause kind of a throbbing sensation, and paresthesias can develop, a kind of burning and tingling sensation as blood flow is again brought back to it. So that's what you see. Mostly you'll notice it in the hands, and almost every time I teach this class, somewhere along the line, somebody, either themselves or someone they know, suffers from Raynaud's, and a lot of times it is idiopathic. It is more common in women, particularly young women. It does seem to get worse, although this is not a cause, but it does seem to get worse if it's got exposure to cold or stressful situations. But it also can be linked to use of tools with heavy vibrations. Think about, say, a manicurist who uses a drill to do with the acrylic nails. I don't know if they still do that, but I think they do. That kind of vibrating tool. That usage, again, not necessarily a cause, but seems to be more commonly seen, but there's no linkage as to, yes, I know why using a vibrating tool causes this problem. It just seems to be linked to it. So we kind of would put that a little bit more into a risk factor. And there also seems to be a genetic link to it, although no gene has been identified, at least not since last I looked, linking Raynaud's disease genetically, although it does seem to run in families, hence the sense of a genetic link. Now, with Raynaud's phenomenon, pulmonary hypertension and then the edema that forms seems to be a cause in Raynaud's, because again it is lack of oxygenated blood flow to tissues, so that can cause Raynaud's. And there are some excessive collagen diseases. Buildup of collagen has been linked to some triggering of the vasospasms that can cause this problem. The manifestations overall for Raynaud's: numbness and periodic loss of function. Again, it's episodic, so it comes and goes. The nails may become brittle, and the skin at the tips of the fingers may thicken, again due to lack of blood flow. It's the formation of scar tissue. Can lead to arthritis, and in very rare but severe cases, it can lead to ulcerations of the vessels, and gangrene can develop. Okay, so those are your three main arterial diseases of the extremities. All right, then we're going to look at some aneurysms. An aneurysm, by definition, is an abnormal, localized dilation of a blood vessel. It is most common in the aorta, but it can occur in any artery. Okay? So it's a dilation, an abnormal, localized dilation of the vessel. Taking a look at the pictures here, it's a bulge. Look at the bulge that forms here. We've got several different versions of the types of aneurysms, this here being the one up here in the cerebral arterial circle. So there are different types. We'll talk about in just a second. What happens is the pressure in the vessel increases. As the pressure increases and pushes against the vessel wall, the wall itself becomes weakened, and the blood pressure increases, the wall will give way to the pressure. So it's certainly linked to hypertension or high blood pressure. It can be made worse by blockages that are forming in and around the area that can weaken the vessel wall. It can be genetically linked. So there are a number of possible reasons for why it can occur. Certainly, in terms of the overall causes, and hypertension or high blood pressure certainly can be linked as a primary cause, because as the pressure goes up, it simply weakens vessels overall throughout the body. It tends to weaken them more uniformly across the body, but if there's already been some atherosclerosis that has built up there, or there has been an infection, trauma, previous aneurysms, something else going on that has weakened the vessel in that area, particularly if there's been a tear and it's tried to heal, so there's some scar tissue, so it doesn't have that pliability or elasticity that it used to have. Those kinds of things can make a vessel weaker, and then with that high hypertension or high blood pressure, it will cause the bulges to form. Now, a true aneurysm is one in which all three layers of the vessel are thinned and bulging. Remember from the previous lecture, the tunica externa, tunica media, and tunica intima or interna, all three layers are involved. That's what a true aneurysm is. And there are three types of true aneurysms. The first one is a fusiform, or also referred to as a circumferential, like a circumference, circumferential. The fusiform is probably the more common term that I would use on the exam, but you may see elsewhere the term circumferential. It means the entire circumference of the vessel is dilated, and that's really what you're seeing here in picture C. That's the entire vessel has bulged all the way around. Again, you're looking at a two-dimensional picture, but if you could see it from a three-dimensional perspective, the entire thing, all the way around, has bulged. In a berry, and by the way, this is showing it in the aorta, the abdominal aorta. Fusiforms are much more common in the aorta. Usually, not so much necessarily in the arch of the aorta, but as you come down from the descending aorta through the thoracic and cavity and the abdominal aorta. The berry aneurysm is a small spherical dilation, and it's usually at the point of bifurcation. Bifurcation is when a vessel branches, so it's at a point where there will be a branching that takes place. And so in our picture letter A here, where you see the berry aneurysm, if you'll remember your cerebral arterial circle, the internal carotids are coming up in here and forming the middle cerebral. The internal carotid is actually the part cut right here, and it forms the middle cerebral artery. These are the posterior communicatings coming down here, anterior cerebrals coming up here, anterior communicating, and again those anterior cerebrals continue on up that way. This is forming the cerebral arterial circle with the posterior cerebral arteries coming back off here. So at this point here where that posterior communicating is coming on up here and joining with the middle cerebral and the internal carotid that's cut, right in there is a major bifurcation. It's actually a three-way branch. It's a very vulnerable area. Things can get lodged in there, and then the berry aneurysm can form. So very common. Berry is the most common type of aneurysm that forms in the circle of Willis, or in the brain just in general. And then this third type, the saccular aneurysm, is not pictured here, so be careful. That's not what's in letter B there. A saccular aneurysm is a dilation off of one side of a vessel, and again, that's not what you're seeing here, so don't be confused by picture letter B. Sacculars would be similar looking to this one in the abdominal, except it wouldn't be all the way around. It would just be on one portion of it, so it's a bulge off of one side of it. And it's most commonly associated with infections. Things like syphilis can weaken vessels and cause that, or with congenital conditions. Again, something you're born with is a weakened vessel area, and as you age and the blood pressure rises, it can cause that aneurysm to form. Then you have false aneurysms, or referred to sometimes as a dissected aneurysm, and one example would be the aortic dissection we'll talk about in a second. In a false aneurysm, only the intima and media, either just the intima or the intima and media layers are involved. Okay, so not all vessels are involved, and as the bulge occurs, blood starts to pool between these two layers. So not all three layers are involved in the problem, but then blood starts to accumulate. It tears in one area or pushes out in one area, and blood gets into this area. This is a life-threatening condition because you're going to have a real problem because there's a tear, and that's what that lower little arrow is showing, that there's actually a tear that occurs in that layer, and blood starts accumulating in there and applying pressure both from what's pushing through and from the outside, and so there's a great risk that it will tear all the way through. This is seen more commonly in middle-aged males who suffer from hypertension. It is also associated with those who have congenital diseases such as Marfan's syndrome. You'll recall Marfan's from the beginning of the course, the connective tissue disorder, the autosomal dominant disease that we talked about at the beginning. The connective tissue weakens the vessels within particularly in the aorta, and as that wall weakens, there's tearing that can occur. So a false aneurysm, not all the vessels, and an aortic dissection is particularly significantly problematic because it's going to lead to tearing. Blood's going to push against, instead of having to push against three layers, with that muscular layer being in there to kind of strengthen, it's now pushing against that outer layer, and it's going to cause it to tear. In terms of manifestations, obviously, in all cases, blood flow is affected. As blood flows through these vessels, it causes turbulence in there. It's not a nice, clean pathway, but blood starts to get hung up in those spots. Turbulent blood flow tends to lead to issues of coagulation occurring there, increases resistance, which further increases blood pressure behind it, causing more push against it, so it actually makes the problem worse. In all cases, there's going to be pain, particularly if this is occurring in the aorta. If it's in the thoracic aorta, it can affect swallowing because you can feel the bulge as you try to swallow against it. Certainly all the organs that should be receiving blood off of that particular vessel. So if it's the abdominal aorta, it can be all the organs from below that point, wherever it might be. If it's in the brain, it's going to be that area of the brain. In all those areas, there's going to be ischemia or ischemia that develops because you're not delivering nearly as much blood. And with this, because clots can form, you can have emboli that develop, or emboli that are circulating through that can get lodged in that area and can increase the risk of tearing. And it's worth noting that this can also wind up being asymptomatic, and a person may not have the pain, may not recognize the loss of blood to the area, a particular area, often linked to what their particular lifestyle is. So if they are already leading a pretty sedimentary, sedimentary lifestyle, they're not up, they're not moving around, they sit around and watch a lot of TV and just do a whole lot of nothing. Well, the demands on the body aren't very significant, and they won't notice the ischemia, the lack of blood flow, until at some point with minor exertion they get up, the pressure increases, and the aneurysm tears, and that often, with that rupturing, can lead to death. All right, just a couple comments on these two terms, thrombus and embolism. A thrombus is some mass, some atherosclerosis, plaque buildup, whatever it may be, something that is attached. Could be calcium that's accumulated in the blood vessel. In all cases, though, a thrombus is attached. It's usually going to develop in vessels that are damaged. So you can see a thrombus developing in Buerger's disease, for instance, any kind of injury, trauma, even with hypotension or low blood pressure, because with low blood pressure, there's slow blood flow, and particularly in the veins, it allows blood that doesn't move will start to clot. Once it clots, it can start to accumulate against and cling to the wall of the vessel. If there are obstructions of any kind, it tends to cause blood to pool in the area. A thrombus can occur in arteries and veins, so it doesn't matter which. It's probably a little more common in veins, particularly deep veins. Think about the lower appendages and the deep veins, because blood moves slower. There's less stretch in those vessels, and therefore they're much more susceptible to that slow-moving clotting blood and the accumulation to develop. Also, since IV meds are given in veins, the meds can be very damaging to veins. Chemotherapy in particular is very damaging to veins, and so makes it much more likely that the thrombus would form there. Thrombophlebitis, the term thrombophlebitis, P-L-E-B-I-T-I-S, thrombophlebitis is an inflammation or inflammatory response accompanied by clot formation. So it's inflammation. Anything itis is inflammation. It's in the veins and is accompanied by a clot formation. So thrombophlebitis is inflammation and a clot formation in the veins. If the thrombus detaches in arteries, it will, if the thrombus develops in an artery and therefore detaches, it becomes an embolism. An embolism is anything that is circulating through the body, some substance that's large and circulating through, and large by what I mean is large enough to flow through a vessel. Large is a kind of a relative term, but it's some substance other than nutrients and things that we want circulating through the blood. So if the thrombus detaches in arteries, think about where it's going. It's going to block the blood flow in the systemic capillaries or the small arteries. So if it's in, say, if the thrombus was in the brachial artery, it breaks free and starts circulating through. It's going to continue down the brachial artery and block something in the lower portion of your arm or into your hand, because it's going to branch into small capillaries there. If it's in a vein, the biggest threat is that it will go to the lungs, because, of course, if it's in a vein, you're going from smaller vessels to larger vessels, and the odds are it will flow fine up into the vena cavas, into the heart, out through the pulmonary trunk to the pulmonary arteries, and then when it gets to the lungs, it branches smaller and smaller, and this becomes a problem. A pulmonary embolism can get lodged in a small capillary in the lung. It interferes with gas exchange and can also cause pulmonary aneurysms. Again, an embolism is an obstruction from some material circulating through the blood vessels. It includes thrombi that break free, but it also can be anything from an air bubble from an IV to pieces of tumor cancer cells, the plaque cap from atherosclerosis. Certain foreign things can get in the blood. Certain medications and drugs can precipitate and release cell debris. There's clumps of lipids. During labor, you have to watch out for the formation of an embolism, as amniotic fluid can sometimes get into blood vessels, so that's always a risk factor. So embolism is something that circulates through. Depending upon where it goes is where the risk is for where the damage might be. Okay, and I think that takes us through this part of the lecture.